Good afternoon to everybody. Thank you so much for coming out. This is our second in our new series, Arts and Entertainment Lecture Series. Our first one was last month, and we kicked that off right with Hurricane Lee, so it only seems appropriate for the second one. We have a little storm, but thank you for coming out. I think today's speaker is going to be fabulous. I'm going to later, in just a couple moments, going to ask my colleague, Dr. Jim Jordan, to announce or give a little more introduction to Andrew Schulman, but his story really is extraordinary. But I just wanted to tell you a few things about Arts Empowering Life that we have offered in this building. For a lot of you, it might be the first time that you've seen this space, and we're really encouraging community involvement down here. We have a new community wind ensemble that meets on Tuesday mornings, 9 to 11, for any retired folks that want to come out and play with us. We encourage walk-ins. We also rehearse 5 to 7 on Thursday evenings if you want to bring your kids. It's a multi-generational group, and we started with 5 people and we had 14 last Thursday, so that's a growing group. The next lecture we will have will be here. The artist will be in person. That will be on November 18th, and that will be on Baroque trumpet. A couple other things that won't be necessarily in this building, but Arts Empowering Life does is they do Advent lessons and carol service at the Church of the Transfiguration. Those dates are December 1 and 2. And we're also going to do Handel's Messiah on December 15th and 16th. And then before Christmas, on December 23rd, in this building, we will have a community carol sing. Last year we did that. We have piano and a few instrumentalists, and come out and sing your favorite Christmas carols in preparation for the season. So without any further intro, this is going to be an interesting logistic today. Andrew is in his apartment in Manhattan. Jim is in that room right there, and I'm going to try to make sure that all of the pieces work together. At the end, there will be a question and answer period for maybe 10, 15 minutes. If you have questions, you read them to me, I'll say them, Sarah will type them, and Jim will communicate to Andrew. So we're technically trying to figure out how this works, but in a moment, Jim will be here to introduce Andrew. Thank you all for coming.
Well, good afternoon. Thanks a lot, Paul. This actually is a great joy to get to introduce Andrew Schulman, who's our speaker this afternoon. In fact, there's Andrew coming on just right now. I would have to call Andrew my newest old friend. We actually met through Pam, my wife, giving me a birthday present of a book called Waking the Spirit. This is Andrew's book that came out a few years ago, talking so much of his story. Pam told me, you need to read this. You're going to love it. Well, she was right. She was so correct about it. In fact, I couldn't put it down, and I decided I needed to reach out to this man. And the first time we met was on the phone for over 2 hours, and that was 3 years ago, and have worked together ever since. I'm actually not going to go into any great detail. Andrew needs to tell this story, but there is a great reason that he is super to go with Arts Empowering Life. Not only is his personal story about what he himself received through the arts right in line with everything from this foundation, but what he now gives to people through the arts based on what he received is equally wonderful. And the story is one that is completely worthy to be told over and over. So with that, I introduce to you and welcome Andrew Schulman.
Well, thank you, Paul and Jim. It's an honor to be here today with all of you to talk about the use of music as medicine in critical care units. I'm not going to give you a lot of facts and figures. I'm just going to tell a few stories. First, though, since the music itself is the most important thing I have to offer, I'm going to play one of the most effective pieces I've used as musical medicine in my 10 years of playing in ICUs. It's called Little Theme in D, and was written by a guitarist I know, Peter Williams. I'll tell you more about this music a little bit later. So, here's my story of how I became a medical musician. In late 2009, I got a phone call from a doctor the day after I had an MRI telling me that I had pancreatic cancer. He actually said 100% cancer and told me I needed to find a surgeon immediately. My wife, Wendy, had gone through breast cancer surgery the year before, and she called her doctor who recommended a pancreas specialist. A few days later, we met with him, and after looking at the scans, he concurred. It was pancreatic cancer. What I remember most of that visit is that before we left his office, he told me that the statistics were that I had a 3.8% chance of living 2 more years. I was 57 years old at the time. For the next 2 weeks, waiting for the surgery, I walked my 2 dogs, yellow labs named Dolly and Paco, in nearby Riverside Park, and I contemplated what it all meant, that my life was probably coming to an end. I also went to the gym every day, and while on the rowing machine, I was comforted by listening to my favorite piece of music, Johann Sebastian Bach's St. Matthew Passion. On the night before the surgery, I thought about what book to take with me to the hospital. On my bedstand were 2 detective novels that I was planning to read, both by Rex Stout, featuring the genius detective Nero Wolfe. The first was called Might As Well Be Dead, which didn't have quite the feel I was looking for. The second, though, seemed perfect. Not Quite Dead Enough. That's the one I took. The next day, at 2 p.m., the surgery began at Beth Israel Hospital in Lower Manhattan. I still remember the fade to black when the anesthesia kicked in. 7 hours later, the surgeon went down to the waiting room to see Wendy, who'd been in a state of fear all day. To her complete surprise, he had a big smile on his face and some really incredible news. They had done a frozen section pathology of the tumor in the middle of the operation, and miraculously, it was benign. As he explained to her, sometimes even a 100% diagnosis is wrong, though rarely. But within a minute, Wendy's joy turned to fear when the doctor's beeper went off and he told her he was being summoned urgently to the surgical ICU. Something had gone wrong and he had to get upstairs immediately. He told her to go to the waiting room near the SICU, as they call it, and he'd meet her there when he could. Now, here is why his beeper went off. When they finished sewing me up in the operating room and put me on the transport gurney, I was fine. But within a minute, my blood pressure plummeted, and if your blood pressure drops enough, your heart stops. I was in danger of becoming a code blue, the hospital shorthand for cardiac arrest. There was a mad dash for the SICU, but 2 minutes before we got there, I had no blood pressure or respiration, and my heart had stopped. I was clinically dead. Fortunately for me, Beth Israel had a great SICU medical team trained by the ICU director, Dr. Marvin McMillan. With great skill, they resuscitated me and put me into a medically induced coma, which they do to buy time, to figure out what's going on, and especially to preserve brain function. As far as brain function, I was already in a lot of trouble. My chart shows that from the time I arrived in the SICU, I was in brain ischemia for 17 minutes, meaning not enough oxygen to the brain, so brain damage was highly likely. As it was, I was a mess. I flatlined a second time that night, and for the next 2 days, there was one crisis after another. Not a single doctor or nurse in that unit thought I was going to survive. Dr. McMillan actually said during a staff meeting, "This guy is toast." To everyone's surprise, I made it to the 3rd day, a Sunday, and at noon my lactic acid number was 17. I love telling this to doctors and nurses because their eyes pop out. Normal is 1.8, and most people don't survive much past 10. Maybe I had 5 minutes left to live, maybe an hour, we'll never know. As I learned later, right around this time, The nurses were talking about a Christmas tree and a widow. A Christmas tree because when a patient was in such desperate condition as I was, they make a last-ditch effort. At the bedside, they place 2 or 3 aluminum stands that are filled with bags of medicine, anything that may turn the tide. And the nurses in this unit call that a Christmas tree. The word widow, that was spoken because Dr. McMillan always told his nurses to come and get him when a patient is on the precipice and he's going to have to give what he called his black bunting speech to the widow. It was just then that Wendy had an epiphany. She was looking in her bag for her cell phone and saw my iPod. The light bulb went off. She turned to the attending physician and said, "My husband loves music more than anything. His heart is beating, but his soul isn't. I believe only music can give him the will to live." She asked if she could put my iPod in. He said yes. She could have 30 minutes, but if there was any sign of agitation, the music had to stop. So, the earbuds went in, but she didn't know what to play, so she just clicked on the first track. What was it? Lucky for me, Bach's St. Matthew Passion. I'm often asked if I heard the music. I did. There was something called coma dreams. They're not actually dreams, but rather hallucinations, and they're often based on what's going on around you. In many cases, a coma patient hears everything. One of the most important things I can share with you today. I had many coma dreams during the week I was in this condition. In this coma dream, which I remember 14 years later as vividly as then, I'm going to visit the widow who I played for every Christmas. Although I was wearing a heavy coat, I was so cold and very, very tired. I arrive at her house, knock on the door, and then she opened it. She was a woman in her 80s, red hair faded, tears in her blue eyes. Later, remembering this dream, I knew it was Wendy, 40 years older. As we did every year, we went into the living room. She sat in a chair against the wall. I sat in a chair in the middle of the room. But I was so tired, I could barely lift the guitar out of the case, and when I finally did, I didn't have the energy to play. I closed my eyes. Then, all of a sudden, I heard the most beautiful music, and I was bewildered. Where was it coming from? I opened my eyes, looked down, and saw my hands moving on my guitar. The music was coming from me. Now, I was even more bewildered. How could I be playing music I'd never played before? I'll add here that because a coma dream distorts reality, I didn't realize it was the St. Matthew Passion. But what matters is that all of a sudden I felt warm, I felt stronger, and I smiled. I kept playing. And then the dream faded away to be replaced by the next one. What was happening in the real world, all of it recorded in my medical chart, is that as the music continued to play, my heart rate and blood pressure, which had been all over the place from the moment I arrived in the ICU, began to stabilize for the first time in 3 days. My kidney function improved, and over the next few hours, the lactic acid started leaching from my tissues. In short, as all the doctors and nurses attested to later, the music literally saved my life. It reversed the metabolic process that was killing me. For years after, the nurses in that SICU called it the St. Matthew miracle. Now here's an insight into how the St. Matthew Passion itself could have had such an effect on a critically ill patient in a coma. Dr. Lewis Thomas, who was known as the poet philosopher of medicine, wrote a regular column for the New England Journal of Medicine called Notes of a Biology Watcher. He ended one of his essays this way: if you want, as an experiment, to hear the whole mind working all at once, put on the St. Matthew Passion and turn the volume up all the way. That is the sound of the whole nervous system of human beings all at once. You may be wondering, though, what exactly did happen that music even as powerful as the St. Matthew Passion could have had such an astonishing effect. The ongoing scientific research in this field still has a far way to go to pin that down, but here's what I can share with you now. One of the leading music therapists working today, Dr. Connie Tomeno, an old classmate of mine from Stony Brook University, told me this when I asked her opinion on what happened. She first quoted Dr. Oliver Sacks, the famous neurologist and author of Musicophilia, who co-founded the Institute for Music and Neurologic Function with her. He wrote, "Nothing activates the brain so extensively as music." In my case, she said, the music entered my brain through the auditory nerve and then traveled into the auditory cortex. From there, many adjacent parts of my brain lit up. Chemicals were then produced that carried a message all through my body. The message was, it's not time to shut down yet. That's the best description I've ever heard so far for what happened to me. Now, let's go back to the SICU. On this third day, I stabilized, but didn't wake up. They kept me in the coma for 3 more days to play it safe. I never regressed, and there were no more crises. On the 7th day, they brought me out of the coma. Yes, I know, you're supposed to rest on the 7th day, but I didn't rest that day, happily so. But as is often the case in these situations, I was in a state of delirium and not able to coherently communicate with anyone. It was the next morning, a Thursday, that Wendy arrived at 8 a.m., and as she pulled the curtain back, he said, "Hi, Wendy." Her smile in that moment was a once-in-a-lifetime smile, especially because I recognized her and didn't have slurred speech. There were no signs of brain damage. She sat down, and the first thing she said was, "Your surgery wasn't yesterday, it was 8 days ago. You went into shock, but they saved you, and most important, you don't have cancer." I was speechless for about a minute. Wendy likes to say that was the longest she'd ever heard me speechless. But during that minute, I could see very sick people in beds nearby. I heard moans and groans and the beeping sounds of medical machines, and I made a decision. I turned to her and said, "With what happened to me, you can't thank God enough, or your doctors and nurses, or your loved ones. To give thanks, you have to give something." I knew I didn't have money to donate, but I had something else. I turned back to Wendy and said, "This place is gloomy. It needs music. I'm going to come back here with my guitar." That was it. My life was about to change. A lot. Now, there were a lot of things that happened over the next few days that I was in the SICU that I found fascinating. I'll share just one of them with you now. On my second day out of the coma, it was in the afternoon, I was resting, and Wendy was reading a book. Then I heard something and started laughing. Wendy turned to me. "What's so funny?" she said. I said, "Now I know who the jazz musician was." Now she was laughing. "Okay," she said. "Who was the jazz musician?" I explained. One of my recurring coma dreams was that I was sitting outside a jazz club on 8th Avenue and 55th Street, looking in the window. It was always 4 a.m. in the dream. There was a pianist, and every time he played the same music, what I thought of as minimalist music, it really got my attention. Very strange, but I liked it. I'll play for you now the 2 short melodies he always played over and over again. So, who was the jazz pianist? It wasn't a pianist. It was the warning beeps from the ventilator machines, which were all over the unit. I'd heard one just now going off in a nearby bed. I'll say this again. A patient in a coma hears everything, unless they're in a deep sleep. So, if you are ever visiting someone in an ICU and they're in a coma, be careful what you say. Dr. McMillan made a plan for me. He thought I'd be in the hospital for a minimum of 2 months. But I left on the 12th day. I was on a mission. I was going to bring music to this ICU. As we left the hospital, we stopped off to see McMillan, who had seen me in those first few days, but I had not seen him because he'd gone off duty before I awoke from the coma. We chatted a few minutes, and then he gave the classic hospital farewell. "We're delighted you're doing so well, and we never want to see you again." My response was fierce. I told him I was determined to return to the SICU with my guitar. Luckily for me, before he went off duty, Wendy had given him one of my CDs, and he'd been quite taken by my recording of the Beatles' "Here Comes the Sun." He told me to go home, get better, and then call him. It was on the second day after I got home that I discovered that I did indeed have brain damage, and only in one area. I had bilateral damage to the hippocampus, the part of the brain involved in forming, organizing, and storing memories. That damage is a fairly common result of brain ischemia. As a result, I'd lost the memory of 12 hours of music and could no longer memorize. When I thought about that, me, a musician, and the only thing I lose is my music, I did think to myself, who said God doesn't have a sense of humor? Anyway, I accepted my fate. I would just have to read music from now on. 5 months later, I called Dr. McMillan. He was happy I had followed up, but told me I'd have to call the director of the hospital's music therapy department, the Louis Armstrong Center for Music and Medicine, one of the most respected in the world. I made an appointment to meet with Dr. Joanne Lowy, herself a leading expert in the field, and the first thing I did when we met was I played for her. I was lucky again. It was a Bach prelude that was one of her all-time favorite pieces. She decided to take a chance with me and allow me to return with my guitar to the SICU. A surgical ICU is the unit with the sickest people in the hospital, so once again, Bach helped me when I needed it. As our meeting came to an end, Dr. Lowy, who had been giving me lots and lots of tips, being that she was a very perceptive person, asked if I had any other questions or concerns. I think she saw something on my face. I told her that I didn't have a question, just a concern that she and her team wouldn't accept me because I wasn't a certified music therapist. I'll never forget her response. She said, "You'll learn from us, and we'll learn from you." And that is what happened. It was a great way to start this next journey in my life. So, 6 months after my surgery, I returned to the SICU at Beth Israel Hospital. I'm going to play something else for you now, another piece I've used many times in musical medicine. There is a famous melody Bach used in the St. Matthew Passion in 5 different settings, based on a hymn, "O Sacred Head, Now Wounded." I had a wounded head, so it was natural for me to arrange it for guitar. By the way, Paul Salmon based his song American Tune on this melody, giving it an added resonance in a modern ICU. Although I I have had no formal training in music and medicine. In my first 3 years back in the SICU, I had the best possible training for what I wanted to do. Hands-on training. I was in an ICU with the medical team that, along with the music, had saved my life. I had a million questions, and there was always someone, a doctor or a physician's assistant or a nurse, who would help me. I'll move forward now to the end of that 3rd year. It was at this time that I started calling myself a medical musician. I wasn't a music therapist, so what was I? I was a professional musician and a team member in an ICU, using music as medicine. It just came to me, medical musician. I'll give you a picture now of the method I developed for each session in the ICU. In some ways, it's simple, and others, not so simple. The first thing you do when you enter the unit, I learned this from Dr. Lowy, is walk around and just get a sense of the room. What is going on in the ICU today? The range is huge. An ICU is a room of life and death. Next, go to a quiet place, often the nurse's lounge in the back, and tune up. Having the best sound from your instrument is crucial. One of the most important things in music healing is the tone quality of the instrument or the recording that's being used. After that, I would go to the main computer monitor in the nurse's station and spend a few minutes, or as long as it took, to look at the vital signs for each patient: heart rate, blood pressure, respiration, and oxygenation. I would triage, going to the sickest patients first. And if someone was in a coma, I would want to start with them based on my own coma experience. It's also when you're in the nurse's station that a nurse or doctor may ask you to go to a patient, but once you're accepted as a member of the medical team, they mostly trust your judgment. After the vital signs review is finished, the next step is to do a slow promenade through the entire unit while you're playing, so the patients who are able to can see and hear you. I have a guitar strap, so I can walk and play. I may not be able to walk and chew gum, but I can walk and play the guitar. From the start, I had a perfect piece of music for this. Now, this is a crucial step. Earlier on, I'd sit at the nurse's station and play. Nurses would ask patients if they wanted music walking all through the unit. Maybe 20–30% would say yes, but if they heard you and saw you, it went up to about 80%. Once the promenade is finished, you then make the decision of where to go first. Of course, if a patient or caregiver or a doctor or nurse asks you to go to a particular bedside, you do that first. So now, you're at the bedside of your first patient. Once you're there, you rely on intuition as to what to play. Most patients in an ICU are not able to make requests, and even if they can, they'd rather not. They're on a lot of medications, they haven't had normal sleep, sometimes for days or longer, and they're very stressed out. They don't want to have to make decisions, although there are always exceptions to that, in which case you do your best to play what the patient wants. Again, what do you play? You develop a repertoire of what I call penicillin pieces, music that has a very high probability of being effective. For me, that's a mixture of classical and popular music, mostly in medium tempos corresponding to the human heartbeat, and mostly in major keys. I also learned early on about what music therapists call entrainment. It's a complicated thing to describe. It's a term from physics. So I'll just say for now that it's a synchronization between the patient and the musician, and it's the key to effectiveness. I learned to create that synchronization by playing music that tells a story. In other words, music that is evocative. That's why I say a medical musician is a storyteller in sound. I would play, and the patient and I would journey together into the world of that music. In essence, you are telling bedtime stories. And if you can get a patient to fall into a deep sleep in an ICU, you're doing one of the best possible things to help their healing process. When you play at the bedside, you can't focus on the instrument. You concentrate on the patient. watching the face, hands, and feet, mostly looking for signs of agitation, which would mean you need to change the music or even stop playing if need be. You also need to be alert to the vital signs monitor hanging above the patient to see if you are helping their heart rate, blood pressure, etc. So you have to be very secure in your playing because you can't concentrate on playing your instrument. It's all about the patient. Okay, now until now I've focused on medical music for patients, but there are actually three constituencies in an ICU. The patients, the caregivers, which are primarily family and friends, and the medical team. Music can make a world of a difference for the caregivers. The music that I started this talk with, the little theme in D, a very poignant little piece of music, is a perfect example of that. I can't go into the technical aspects of that music right now, but I'll just say that it's a piece that's filled with hope and at the same time an awareness of the gravity of the situation. And so it's a piece of music that can bond a group of people together sitting around the bedside in the moment better than anything else available to them in an ICU. I have played Little Theme in D hundreds of times when loved ones sat around a patient who might live or die, when they are all in a state of fear and anxiety, and each time the music has given that small group something to connect them in an emotional way that helps them, and most important, it therefore helps the patient. And how does music help the medical team? ICU staff work under great pressure and stress every single day. ICU burnout is a major problem in all hospitals. I learned early on to encourage the staff to share with me the music they like the most. For Dr. McMillan, it was Here Comes the Sun. For one of the nurses, it was Bésame Mucho, and so on. It was always a pleasure for me to play what made them happy. When I would see them under a lot of stress, I would play their music for them, and the relief it gave them was unmistakable. Having a strong relationship with the medical staff is vital for a medical musician. If they don't accept you as a fellow healer, it just won't work. Here's a little story of one example of how I became a team member to a particular nurse. In January 2016, I began a monthly residency with the title of Medical Musician at Berkshire Medical Center in Pittsfield, Massachusetts, where Dr. McMillan had taken a position as critical care director. On my first day there, when I walked into the ICU with my guitar and began my promenade, a nurse hurried up to me, demanding to know what I was doing there. I explained, and she backed off, but she was still very negative, even hostile. She remained so for my first 3 visits. It was in the 4th month that I happened to play for one of her patients with very high blood pressure. It was in the 160s, dangerously high for a critically ill patient. The medications had not been able to help at all. And as it turns out, music is often very effective with high blood pressure. So, 20 minutes later, the patient's blood pressure was in the 120s. I glanced at the nurse, but her expression was still highly skeptical. She wasn't buying it that the music had so dramatically lowered the blood pressure. The next day, another of her patients, also in the 160s, 20 minutes later, the 120s. I glanced at her now, and she was thinking. 3rd day, just an unusual coincidence. Another of her patients in the 160s with blood pressure. 20 minutes later in the 120s. This time the nurse walked over to me, leaned in, and said, "Andrew, could you go to bed too now?" That was it. She had finally accepted me as a team member. And that's as it should be. The medical musician has to be helping the patients, and you need to show that. But if you do, you're on the team. In my years as a musician in ICU, I've played for thousands of patients. Here is a brief account of one of my favorite stories. In my book, Waking the Spirit, this is the chapter called Alice Blue Gown. One day, as I entered the unit, I saw a patient in bed 7, in her 60s, eyes swollen shut, hair on one side of her head shaved, skin very pale, no movement at all. She was wearing a blue hospital gown, and her last name began with the letter A, which is why I called her Alice Blue Gown, after the old song by that name. A second-year resident I knew well told me she had a massive stroke and there was little hope for her. They weren't sure if she had any cognitive function left at all. In these cases, the patient often goes into an acute care facility where they're warehoused until they die. I decided to go to her first. Her heart rate and blood pressure were high, but as I played, they began to come down. However, that was the only sign of change. When the music starts, even in a coma patient, you usually see something physical happen, just a twitch in the face or hand movement, but with Alice, nothing. Even so, as all the other patients that day were in pretty good shape, I decided to play for her, just for her. After about 45 minutes, I took a short break, and as I talked to the young doctor, we heard a noise. It was her, making a gasping sound, and although her eyes remained closed, her face began to redden and her vital signs shut up. I asked the doctor if he thought it was because the music stopped. He didn't know. So I went back to her bedside and began to play again, and sure enough, she settled down. I played another 45 minutes and then it was time to go. Other than that agitation and the change in her vital signs, there had been no sign that she was home, so to speak. I packed up, and as I was leaving, I went over to her, leaned in, and said, "Mrs. A, I enjoyed playing for you." Just then, 2 beeps sounded from the intracranial pressure monitor she was attached to, which startled me. Had she understood what I'd said? I went over to one of the nurses nearby, Rosie, a nurse who had taken care of me when I was a patient, explained the situation, and asked if she thought it was possible this woman was still functioning inside. Rosie said, "Let's see." She went over to Alice, took her hand, leaned in, and said, "Mrs. A, did you like the music? If you did, squeeze my hand." We waited 5, 10, 15 seconds, nothing. Then it happened. Our hands slowly tightened. However, Rosie turned to me and said, "It might just be a reflex reaction." So she asked another question. "Mrs. A, if you want the musician to return home, I'm sorry, if you want the musician to return tomorrow, give me a thumbs up." I hope she didn't want me to return home. "Mrs. A, if you want the musician to return tomorrow, give me a thumbs up." The seconds ticked by, 5, 10, 15, 20, nothing happened. I was then ready to give up hope. Yes, it was a massive stroke, no one was home, and I berated myself for thinking and hoping otherwise. And then, to my astonishment, and Rosie's, Alice's hand slowly, slowly, slowly turned, and as slowly, her thumb went up. Rosie and I were astonished and overjoyed. It was the biggest lesson of my time as a medical musician, never give up hope, and a welcome reminder that Oliver Sacks was right. Nothing activates the brain as much as music. The day after I played for her, I returned to the unit to hear her neurologist tell another doctor that she was puzzled by the sudden improvement in her condition. Was it the music? I can't prove it, but I do believe it made all the difference for her. Okay, here's one more patient story from the SICU. This one is about the man I called my English patient. It's from the Wild Horses chapter in my book. I was playing near the nurse's station one day when a very elegant woman with an English accent approached me. She reminded me of my mother, about the same age. She told me her name was Trudy and said she was enjoying my music, and went on to tell me that her son, who was in bed 4, also loved music. She then told me his situation. He'd had a surgery, there were major complications, and he was in a medically induced coma. She asked, would I come to his bedside? Of course I said, and we went to him right then and there. That was the first time I played for Elliot Bernard. I can tell you his name because he's given me permission to use it in my book and when I do these talks. Elliot was quite a music lover with a wide range of interests. A former chairman of the London Philharmonic Orchestra and a friend of Mick Jagger to boot. Long story short, his condition kept worsening. At the end of the following week, when I entered the unit, Trudy rushed over to me, beside herself with anxiety. Elliot was at the precipice, she said. Could I bring my guitar right away? It so happened that the day before, I had bought a book of all the Rolling Stones songs. As I made my way to bed for it came to me, what to play. My favorite Rolling Stone song, and as I heard him say in an interview, Mick Jagger's favorite too, Wild Horses. One of the lyrics came to me as I sat down to play. Wild horses couldn't drag me away. Wherever Elliot was in that moment, I wanted him to hear that. With me and Trudy at the bedside were the attending physician and 2 nurses. I began the beautiful guitar intro to the song, which leads to that very poignant melody. It's a long song, 6 minutes. I played it twice. And that day, I experienced one of the most powerful moments of my life. What the St. Matthew Passion did for me, Wild Horses did for Elliot. It pulled him back to life. He stabilized, and we watched his vital signs change significantly for the better. The music saved him as it had once saved me. But that's not the end of the story. They brought him out of the coma the next day, and I continued playing for him for another week. One day, he had to be brought down to the radiology department for a scan, but there was a foul up, and he was left lying on the transport gurney just outside his room for about 10 minutes. He'd been very upbeat since coming out of the coma, but with this minor setback, it was finally all too much. He looked terribly depressed. An idea came to me. When they got the go-ahead for him to leave the unit, I waited until he was just a few feet from where I was sitting, and then I played this. Rolling Stones. It sounded better when I did it in the unit. I can't get no satisfaction by the Rolling Stones, and he got it immediately. As he rolled past me, he threw his arms in the air, both legs kicked off his blanket, and that day our little rock concert lifted the spirits of the whole unit. And so I say this to you, only when a musician is a team member in an ICU can you have that kind of exuberance which benefited everyone that day. Now, I'll finish this part of my talk to say this. I've shared some exhilarating stories of music and medicine with you, but being a medical musician in an ICU is far from always being exhilarating. As I've said, an ICU is a room of life and death, and no matter how much you try, you can't save a terminally ill patient with music or medicine. The most difficult thing I had to learn in my first years was how to cope with the sorrow you feel when people with whom you shared a relationship with died in the unit. But even here, there is comfort. I have always felt that the greatest grace a musician can have is to play music for someone in their final hour, especially in an ICU. Instead of the only sound they hear being the beeps of medical machines and the voices of people they don't know nearby doing their jobs, I have been so fortunate as to be able to ease the way with soothing melodies, having had the chance to help a fellow musician, having had the chance to help a fellow human being pass through that ultimate reality has been a blessing. Now I will finish up my talk with you to talk about the big picture of this use of music and medicine. I'm part of a field called music and medicine. That's the general term given to the big tent filled with music people who help to heal the sick. The core profession, since 1950, is called music therapy. To learn more about that, I suggest you go to the website of the American Music Therapy Association. They have a great website. I think it's called musictherapy.org. Then in 1994, another organization arose, the Music for Healing and Transition Program, which trains people to be certified music practitioners. There is also something called the Clinical Musician Certification Program, presented by an organization called Harp for Healing, which, despite the name, is open to most instruments. And there are other specialties in music and medicine, which you can easily Google. In 2018, I co-founded the Medical Musician Initiative, which focuses on training professional musicians to be members of the medical team in ICUs. As with so many others, our workshops were stopped by the pandemic, but we are hoping to continue when that is possible. Now, there is a question many of you may have. Is all of this medical music a new thing? No. Medical music is actually one of the oldest healing therapies in human civilization. All ancient civilizations had music as a core modality in their healing techniques. One of the best examples can be found in the Old Testament, the story of young David playing his harp for King Saul, who was, as the Bible describes, tormented by evil spirits, probably a deep depression. His advisors sought out someone who knew not just how to play, but how to play well to heal him. There was also the famous Greek philosopher and mathematician Pythagoras. He played the kithara, an ancestor of the guitar, and he founded a school for healing music. He was the first we know of to call it musical medicine. For those of you who want to know more about the history of music and medicine in different cultures, I'll recommend this book, Music Therapy and Introduction by Jacqueline Schmidt-Peters. She covers the whole gamut. This use of music and medicine lasted for thousands of years until the 18th century, when European and American doctors turned much more to science. Anything that wasn't scientific in their eyes got pushed out, and that included the musicians. A revival of sorts started with the American Civil War. Doctors noticed that when local musicians were brought into the hospital to play for the wounded soldiers, it had a beneficial effect for the patients and the staff. Same with World War I. Between the World Wars, several universities started to teach about the use of music as medicine, and in World War II, more attention was paid to music in the soldiers' hospitals. This is what eventually led to the landmark conference held in 1950 that began the music therapy profession. Interestingly enough, it was the quest for science that pushed music out, and ironically, it's science that's bringing us back. Starting in the 1980s, researchers began doing brain scans, especially MRIs and fMRIs, while music was being played, and they discovered that what Oliver Sacks was talking about, that music lights up the whole brain, is demonstrably true. And when the whole brain lights up, crucial chemicals are produced that help us. But here's the thing. Modern hospitals operate on hard data, and collecting that data has been slowly evolving to prove music works as medicine. I'll read something from the prologue in my book. On August 13th, 2015, The Lancet, the leading British medical journal, published a new study that confirmed that listening to music before, during, and after surgery reduces patients' anxiety, pain, and their need for painkillers. The study team, led by Queen Mary University of London, analyzed the results of 73 randomized controlled trials that looked at the impact of music on post-operative recovery, and their findings confirmed the positive link between music and lower levels of pain, anxiety, and pain medications. This was true even in cases of surgery performed under general anesthesia. The study concludes, music is a non-invasive, safe, and inexpensive intervention that can be delivered easily and successfully in a hospital setting. We believe that sufficient research has been done to show that music should be available to all patients undergoing operative procedures. I can tell you that there have been a fair number of studies since then, and the most recent one I know of at Georgetown University Medical Center, where a study funded by the National Endowment of the Arts just concluded. Physiological and neurological data has been captured from 15 end-stage liver transplant patients and 28 health control participants. This data is now being analyzed by Georgetown University's Department of Biostatistics. The study was designed by Julia Langley, faculty director of the hospital's Arts and Humanities program, and Georgetown neuroscientist Dr. Jagmeet Kamwal. It has been a great honor for me to have been asked to record all the music for the study. They also allowed me to establish the dose and duration. The dose, the music, classical and popular, was from my collection of penicillin pieces and organized into the duration. 3 sets, morning, noon, and night. Each set comprised of 5 pieces and about 20 minutes in length. We hope to have the results soon, and then Dr. Kamwal will write a paper about what we did. I started this talk with music, and I'll end with music. If there is a single problem that modern critical care intensivists struggle with, it's how to deal with something called ICU delirium. What happens a lot is that patients in the ICU, overloaded with drugs and in a very alien and inhospitable environment, sink into an extreme form of anxiety. It took years to understand how dangerous this is and what the long-term effects are. As it turns out, music is one of the best interventions for treating ICU delirium. I intuited early on that you don't play happy music for severely depressed people, but you also don't play deeply sad music. There's something in between that is just right, a sound that is bittersweet. 2 years ago, when I was in a bout with my own depression, something I've struggled with all my life, I wrote this piece, Elegy, an homage to one of my first music teachers. There's an old saying, physician, heal thyself. In this case, musician, heal thyself. We used this piece in the Georgetown study, and I'll leave you with it now.
Andrew, the live audience is giving you a great round of applause at the moment. Pardon me, which I must say, the audience is giving you a great round of applause at the moment, Andrew.
Thank you, everybody. Thank you.
And I must say, I was sitting here, I couldn't. I just had to sit and take that in for just a moment. I understand them and I understand both, because the impact of what you've said over the last hour is going to leave us with a lot of things to think about. A lot of very positive things and a lot of very deep emotions impacted with this. We have a couple of questions. We've got time now if you're ready to take a few questions from audience members.
Sure.
Right off the bat, and you talked a little bit about it, someone's asking that, this is very exciting, the thought of getting into this field. Is this something that how would they go about that? Where would they start? I know you mentioned the website, but if they're starting off in an undergraduate degree and just getting started in music, how might you help them consider doing something in this?
Well, you have to keep in mind, I had obviously this very, very unusual situation. I was a professional musician for 35 years, had that medical crisis, and wound up in that hospital. And it's in a hospital where I was under the aegis of a very reputable music therapy program, one of the finest. So I had that unusual situation. Barring somebody else having another kind of unusual situation that might bring it into them. If it was a young person, as you said, an undergraduate, my recommendation is that they become a music therapist. I think that is the best way to get into the field. And again, go to that website, to the American Music Therapy Association website. The music therapists have the most extensive training, and they are involved in using music to help people in an extremely wide variety of settings. Not just hospital, not just medical, psychotherapy, and all different kinds of things.
Right.
The other organization, if somebody is, let's say, older than college age, is already a professional musician, then the other organization that I mentioned, Music for, I'm having trouble remembering the full name, Music for Transition and Healing, I think. Look them up also. They have a very, very good training program. Those people are certified music practitioners. They get a degree, a certification called CMP. And all of that is board certified, okay?
Okay.
Somebody like me, I'm not board certified. And I just have this unusual situation, and I don't recommend to anybody getting into music and medicine the way I did.
No, I don't think, pardon me, I don't think they want to take that path. However, you have opened a great wide path and doors for this. I think I've got another question coming here. Let me grab hold of it. Okay, here's a question for you. My dad was a surgeon and a musician. He always plays music when he operated. That was in the 1960s to the 80s. He must have had good instincts. I happen to know that lady, who was a musicology lady at Eastman years ago when we were students. And this is something that I think moved her greatly. But she obviously catches the fact that there's an instinct here. I have surgeons who are also quite fine pianists, surgeon friends. In fact, one I told years ago, nobody played ragtime better than he did. And he simply wanted to be a surgeon instead.
Yep.
The other question that just came along was, did you ever find that doing what you were doing week in and week out with various patients, did you find that affecting your own compositions? Did you find it affecting your own approach to playing when you weren't in the ICU? How was it changing you as a musician when you were out playing a different type of performance?
That's a great question, and the answer is yes, it had a very, very big effect on me. In the first years that I was doing this, I was still playing a lot of concerts. And the kind of concentration that you have to have sitting at a bedside in an ICU, playing for somebody who is critically ill, is a much higher level of concentration than I'd ever had before. And as I said, in the whole time that I am playing at that bedside, I'm not looking at the guitar, I'm looking at the patient and I'm looking at the vital signs computer monitor above them. Now, the analogy that I use to describe this is actually the chamber music analogy. And what we are taught from our teachers when we're coming up, I'm sure you were taught this, we're all taught this, that when you play chamber music, you divide 50% of your attention to your own playing and 50% to the other people who are playing. You're listening and you're playing at the same time.
Exactly.
And so the medical music analogy is chamber music.
That's actually really great because you spent a lot of the day talking about team concept and working together with the surgical staff, the medical staff as a team member. So that's something people can take and run. Let me see if I've got another question. I think we've got a couple of questions from the live audience.
Okay, Jim, can you hear me now? I'm not sure how this is all working. Are there questions in the hall here that people would like to ask Andrew? Yes.
You play the guitar? Are there other? Hi, Andrew. This has been wonderful. Thank you so much for sharing with us. My question is, you play the guitar. Are there certain instruments that lend themselves to music in this way, or singing, or there's some that don't lend themselves? I'm a bassoonist. I can't imagine going into playing.
Andrew, the question is, do you play other instruments that lend themselves to... Oh, no, sorry, I misunderstood the question. Do other instruments lend themselves to this kind of playing in the ICU?
Yes.
This is coming from one of the gentlemen in the audience who happens to be a bassoonist.
Yeah, I was going to say tuba. but Howard Johnson, the great tuba player, could have sat at a bedside, I'm sure, and played. So here's the thing. I once had a conversation about this with Connie Tomeno, Dr. Connie Tomeno, the music therapist. And the most important thing is the sensibility of the player. That's the most important thing. Then I would say the next importance is, now again, an instrument that's inherently very loud. Now, I always joke about the tuba, but an instrument that's very loud is not going to be effective. You probably can't get too quiet. I'm sure you've played the clavichord, Jim, right?
Oh, yes. Yeah.
The clavichord would be a perfect instrument at bedside. The clavichord is one of the older keyboard instruments. It's small, it sits on a table, and you can actually do a vibrato on a clavichord, the only keyboard instrument where you can do a vibrato. So if you're a violinist, I know violinists who do this work. They'll just play softer. They'll also play a little lower in range. They're not going to go when the violin goes very, very high, as exciting as that can be in a concert, it's not going to be effective probably at a bedside. Daniel Levitin, who's the author of the book,
Yes.
This Is Your Brain on Music, which has been the best-selling book for many years in this field about how music works with human beings and works with the human brain and et cetera, et cetera. He has an article that he wrote where he stresses something I said earlier in my talk. Timbre is extremely important. that it's a beautiful sound, and it is very, very, very important. So I'd say that there is a range there, and it has to be worked out by the individual.
And you mentioned actually a really important word, and that is beauty. The beauty, and then of course the timbre, because those are the things, again, you've been describing this afternoon that have the impact on that patient. Let me see if there's one more question, Andrew. We have time for one more.
I think we have one more question here.
It'll take just a moment to come through.
Okay.
Hello, I just wanted to say thank you so much for today. I am actually a product of Dr. Connie Tomato and the Neurological Institute of Music. So everything that you've said is, I have seen it and I am behind you 100%. And thank you so much for doing what you're doing. I did my internship with her at the Neurological Institute of Music and Dr. Oliver Sacks.
Jim and Andrew, that was really a thank you from all of us out here, and I will second what I'm sure, and I know there's a great
Did you actually
delay.
know Dr. Oliver Sacks? Had you worked with him? We do have somebody here today who wants to give you a thank you personally, who had worked with him.
I didn't know him, but I emailed him when I was writing Waking the Spirit. And he sent me a wonderful response and basically said at that point that his best advice to me would be to contact Connie Tomato. As I said, she co-founded the Institute for Music and Neurologic Function with him. And
Right.
she was the music therapist that he worked with for 25 years. So I didn't meet him, but I did have that contact with him. And by the way, there's a wonderful little part of this story, which is I didn't recognize the name, but when I had first gone to play, on the very first day I went to play at Beth Israel Hospital after my surgery, I remember a conversation that I had with an undergraduate when I was at Stony Brook. And she was the first music therapy student at Stony Brook. I was the first classical guitar major. And we had once this hour-long conversation in the hallway in the music building. And she was on fire about this new thing she discovered called music therapy. And when I went into the hospital to play, I just had this picture. I didn't remember her name. But I had this clear picture of her in my mind.
Mm-hmm.
So several years later, when I'm writing the book, and I get the email from Dr. Sacks, and he says, Connie Tomato, I Googled her. I saw right away, that was the same.
That was her.
That was her.
Andrew, we have got to stop, unfortunately. It would be wonderful to continue, but I can't thank you enough. I thank you on behalf of Arts Empowering Life for joining us today. Thank you for the inspiration that you've given us all here today. And we hope at some point we can talk with you again.
That would be wonderful, and thank you so much for inviting me. I really greatly appreciate it.
Absolutely. Have a great rest of your day, and thank all of you for joining us today.
Bye, everybody.
Bye-bye.